Dr. Yang, Yudong Yang, who's from Cedars, Mayo trained, and is going to update us on HCC markers that are non-invasive. Dr. Yang.
Good morning, everyone. Thank you so much for inviting me to speak at the meetings. And I realize that we are almost 15 minutes late, so I'll try to shorten my presentation to okay, so to make sure that we can finish things on time. So I'm going to talk about the imaging biomarker test for HCCs and covers and the blood-based biomarker test for HCC detection and also novel approach for the detection of the early stage of HCC. So let me start with the HCC diagnosis algorithm. As you are familiar with, the patient with the cirrhosis of the liver or chronic hepatitis B are recommended to undergo HCC surveillance with the ultrasound without alpha-fetoprotein every 6 months. If the surveillance test shows abnormal result, namely a lesion measuring 1 centimeter or larger, or AFP level over 20, the patient is recommended to undergo dynamic CTs or MRI. In European guideline also recommend contrast-enhanced ultrasound as an option too. And if the CT or MRI shows the lesions, that lesions are classified based on the GALAD classification. GALAD 1 and 2 are usually considered benign, that the routine surveillance is recommended every 6 months. GALAD 3s are indeterminate lesions and representing up to 30% of chance of having HCC. Therefore, they are recommended to have short-term follow-up MRI or CT and in 3 to 6 months. GALAD 4s are probable HCC, up to 60 to 70% of those lesions representing HCC. Therefore, a multidisciplinary discussion is recommended for consideration of the biopsy or a very short-term follow-up cross-sectional imaging in 3 months. And we can confirm the diagnosis of the HCC based on the GALAD 5 finding, if the imaging characteristic is not the confirmatory, HCC diagnosis could be established based on histology. So even after we get diagnostic imaging, so we have the lesion classified like 5 different categories, meaning that the imaging is not perfect, and also still we see a lesion that we cannot be fully characterized, that there's the area that definitely that we can improve to refine the surveillance and diagnostic algorithm of the HCC. So speaking of the alpha-fetoprotein and ultrasound, those are the standard surveillance tests for detection of the HCC and HCC surveillance program. How good are they in detection of the HCC? So this is the meta-analysis that summarize the huge number of the cirrhotic patients and then HCC case. The sensitivity of the ultrasound for detection of the early stage HCC was only 45%, like less than a flip of coin. When combined with the serum alpha-fetoprotein with the ultrasound, sensitivity of these two tests for early detection of the HCC was 63%, meaning that it's still missing more than a third of the early stage of the HCC with a standard test that we use in our daily practice. Definitely, there's a huge unmet need and to improve the HCC surveillance test to increase the accuracy. So people start recognizing this limitation of the ultrasound-based surveillance. So people start using the MRI as a potential tool for HCC surveillance program. And the accuracy of this MRI for early detection of the HCC has been clearly demonstrated. A PRIUS study, which is a prospective surveillance study of 400 patients with cirrhosis, that they have the paired ultrasound and then the dynamic MRI of the liver for early detection of the HCC. So MRI has way higher HCC detection rate, 86% versus 27% with the ultrasound. And also it has the much lower false positive finding compared to the ultrasound, supporting the use of the MRI as a potential surveillance test for HCC. And also this group also published the cost effectiveness analysis suggesting that MRI, in especially those high-risk cirrhotics, is cost-effective approach for early detection of the HCC. But using this MRI as a routine surveillance just is challenging because of they have the long scanning time, it's expensive, the MRI machine is limited, so we cannot offer this MRI test for all patients who need their surveillance. Therefore, people start kind of wondering whether we can use some abbreviated, simpler MRI with the limited number of the sequences to reduce the scanning time and also make it more available to wider population who need a surveillance program. And this is the recent meta-analysis of the utility of the abbreviated MRI for early detection of the HCC. As you can see, this meta-analysis summarized 15 study of the over 2,800 screened patient. The sensitivity of the early stage of the HCC detection was the 86% using abbreviated MRI. If you look at the right lower corners, that you can see the sensitivity of the all different combination of the abbreviated MRI, like different combination of the different sequences, has the superior sensitivity and compared to the ultrasound when the specificities of the abbreviated MRI was preserved. Again, highlighting the potential utility of using abbreviated MRI for a routine surveillance program. There are prospective imaging studies are going on to evaluate the utility of the MRI, abbreviated MRI, in routine HCC surveillance now. The readout of this trial will likely be available in the next 3 to 5 years. So what is the guideline currently of using MRI as a tool for HCC surveillance? AASLD recommend using MRI in selected patients with the high likelihood having the inadequate ultrasound, especially for those who had the abdominal obesities or those actually with the metabolic etiologies like the fatty liver disease. They have the lower accuracy of detecting HCC. Or ultrasound is attempted, but the quality of the visualization is inadequate, that cross-sectional imaging could be used according to the AASLD guideline. What about EASL? Quite similar. They recommend, consider using the CT or MRI-based surveillance in a listed patient for liver transplantation or those who had the poor quality ultrasound. So we, in our practice at Cedars, we use these MRI for our patient and the cancer surveillance quite a bit, especially with the growing population of the cirrhosis with the underlying NASH, cirrhosis, and obesity, where the ultrasound performance is not as good. So let's talk about the blood-based biomarker for early detection of the HCC. Imaging is always challenging to schedule. A patient needs to call the imaging center to get imaging to set up, and also often it's more costly and so inconvenient. So also a recent survey suggested that the patient prefer the blood-based cancer screening program than imaging because of its convenience. So what are the blood tests out there that we can potentially utilize for early detection of the HCC? I'd like to introduce the alpha-fetoprotein L3% and DCP as an outstanding blood-based biomarker for early detection of the HCC. So AAPL3% and AAPL3 is a fucosylated isoform of the AAP. So you can calculate the percent of the AAPL3 isoform out of the entire the AAP. That if this percent is over 10%, it's a good indicator that patient has the HCC. And the DCP is another serum protein, non-carboxylated immature form of the prothrombin that can go up in the presence of the HCC. That those two tests are FDA cleared for HCC risk assessment. And then in fact, we use these two markers in addition to AFP in our routine HCC surveillance program at Cedars-Sinai. This is the case that I saw in my clinic earlier this year, 68-year-old woman with a NASH cirrhosis of the liver who presented to our transplant center for liver transplant evaluation. So we measured this tumor marker level as a routine transplant evaluation lab that this patient has the AFPL 3% of the 61% is quite elevated, and the normal reference range is 10%. And AFP mildly elevated at 19, and DCP was normal at 1.6. And MRI of the liver with the IV contrast didn't show any liver mass, and then cirrhotic liver. We repeated the panel again because of the number was like grossly abnormal. And this time AFP level was 4,000. And DCP was rising too. And MRI of the liver shows the infiltrative cancer with the tumor thrombus. This is another patient that I saw last month, and who's been listed in our transplant listing over the past 5 years for hepatitis cirrhosis of the liver. Patient has been doing well, and but earlier this year, AAPL3 level was usually normal, but it went up to 14.9, and DCP was 30, while AFP was normal. And the MRI of the liver shows cirrhotic liver without any liver mass. And this panel was repeated. AFPL3 rose to 36 and DCP 149. AFP was still normal 5.7. This tumor, it was a pretty large tumor. I don't remember exactly, but it was an infiltrative large tumor. So apparently the tumor probably was there even before, but the MRI is incomplete, especially for assessment of the infiltrated tumor. But unfortunately, this patient was found to have the advanced tumor that was not detected on the MRI, but based on these two other tumor markers that was there even before. So highlighting the role of this imaging biomarker for the HCC detection that may not be detected with even with the cross-sectional imagings. So I'd like to introduce the GALAD score. Many of you probably might be familiar with this GALAD score using three serum protein marker, AFP, AFPL3, and DCP, and age and gender that we can predict whether someone has the HCC or not. This model was developed this multi-center, multi-country cohort, and 5-10 years ago in UK and Germany and Japan. As you can see, the performance of this GALAD score was outstanding with the area under the curve consistently above 0.90 for early detection of the HCC. And this is our study, first validation of the GALAD score in the US, and also first study showing the superiority of the GALAD score to ultrasound for early detection of the HCC, that we showed that GALAD score has the higher area under the curve compared to ultrasound. And also, you know that ultrasound performance decrease in patients who had the ascites or advanced cirrhosis. It's well known, but performance of the GALAD score was not affected. And when combined with the ultrasound and the GALAD score, it's almost a near perfect performance for early detection of the HCC. This is our recent meta-analysis of the GALAD score, and after we published and then other published that we summarize the result of the performance of the GALAD score, and it worked pretty well. I would like to emphasize one thing, that it worked really well in phase 2 study, stratified by etiology, geographic lesions, and stage. but its performance was some decrease in phase 3 study, where this is more robust form of the biomarker study setting, where we can more objectively assess the performance of the biomarker for early detection. Sensitivity dropped down to 58% when summarizing two phase 3 biomarker study. The caveat is that the study was relatively small, that the larger phase 3 validation study is ongoing. Again, the readout from this biomarker trial will be most likely out sometime next year to have more sense on GALAD score. So these serum protein marker GALAD scores are really outstanding and promising, although we still need a little more evidence to show how well it's performing. So I think that people try to see how can we further enhance the performance of these GALAD score or the protein marker for better detection of the early stage HCC. And the people start using this liquid biopsy approach for early detection of the HCC. What is liquid biopsy? Basically, liquid biopsy is to get the cancer even DNA or RNA information from the peripheral blood without putting a needle into the tissues, and then get the DNA mutation profiling. So this has been getting attention to monitor the cancer biology, early detection of the cancer from the blood draw. So the tumor have the progressions, proliferation of the cells and shed their DNA and RNAs and cancer material into the circulation. And among all these different type of the genetic epigenetic material, epigenetic marker cell-free DNA methylation has been getting attention for early detection of the many type of the cancer, because of this DNA methylation pattern is organ specific. So if you look at the DNA in the peripheral blood and look at the methylation pattern, you can tell which organ shed this DNA into the bloodstream. And also it's cancer specific. So as cancer, there's a malignant transformation, there tend to be a hypermethylation of the tumor suppressor gene, and thereby downregulating the expression of the tumor suppressor gene, and hypomethylation of the oncogene. So it's kind of the overactivate the oncogenes for promoting the cancer. So cell-free DNA methylation has been getting attention, and this is the Helio liver study that analyzed the 77 methylation site of the 28 genes, plus the 5 markers from the GALAD score. And this performance of this panel has been studied in the phase 2 biomarker study of the 120 HCC patient and 125 control, where the area under the curve for early detection of the HCC was 0.92, and which was the superior to the GALAD score or the individual serum biomarker. HCC OncoGuard has been also published for early detection of the HCC with a promising result. Here they use the 3 cell-free DNA methylation markers and also 2 serum protein biomarker for early detection of the HCC. And the performance has been demonstrated in this phase 2 biomarker study, where it shows the area under the curve of 0.88 for early stage of HCC detection. This HCC OncoGuard and Helio liver test has the larger scale biomarker study. The Helio result will likely available sometime next year, and OncoGuard is still ongoing and enrolling patient for larger scale validation of the performance, and maybe potential tools that might become available. You can still order it, but I think that more robust evidence will be available in the upcoming year. I'm going to finish my presentation after introducing the HCC-EV, extracellular vesicle. What is extracellular vesicle? Extracellular vesicles are the small vesicles shed from the cell, but it doesn't have the full nuclei, so it cannot replicate, there's no like replication of the DNA, and so, but it contained the cargoes of the protein, DNA, and RNAs in it. So, and also these EBs are, so it's kind of being used for cell-to-cell communication and to transmit some of these the biologic information between the cell. And these EVs are released into the circulation in relatively early stage of cancer patient, and also they remain stable in the circulation. So has been getting attention as a biomarker for liquid biopsy for early detection of multiple different cancer, including HCC. So our team with the UCLA developed HCC EV surface protein assay, which use the two different process, click chemistry for isolation of the HCC EV and Immuno-PCR for quantification of the HCC EV. So initially, we get the plasma from at-risk patient population, and then we use 4 different HCC-associated antibody conjugated with the TCO, which can have a click chemistry with the modified TZ, that is attached to the click bit. So this HCC-EB is getting attached to the click bit, and later on, this is exposed to the DNA1 and DNA2 grafted anti-CD63 and CD9, which is the EB surface protein, and for the Immuno-PCR to see how many of the different subpopulation of the HCC-associated EBs were isolated. And then we get the 8 different subpopulation of the HCC-EVs, and then using the logistic regression analysis that we identify these independent subpopulation of the HCC-EV for early detection of the HCC. And this study the model was developed from the UCLA cohort of the 45 early stage HCC and 61 cirrhotic control, and then validate the performance at Cedars cohort. And the, again, patient characteristics of the derivation cohort, and about half of the patient population were non-viral metabolic etiologies, reflecting the contemporary etiologies of the cirrhosis and HCC. And then, as you can see in the right upper corner, the heat map clearly shows this 8 subpopulation of the HCC-associated EVs are higher in HCC group than cirrhosis group. And then we came up with the HCC-EV ECG score using 3 different subpopulation of the EB, which has the area in the curve of 0.95 for early detection of the HCC. And this was validated at the Cedars cohort, pretty similar patient characteristics. And again, the heat map shows these 3 subpopulation of the HCC-EV higher in HCC compared to cirrhotic control, and which again, we're using the same exact models, has the area in the curve of the 0.93 for early detection of the HCC. And it has a superior performance for detection of the HCC compared to alpha-fetoprotein. And all these different subgroup analysis again demonstrated outstanding performance for early detection of the HCC. Finally, when combined with the ultrasound, and it has near perfect performance for early detection of the HCC, with a sensitivity of the 96% and specificity of this 91% for early detection of the HCC, which is again superior to alpha-fetoprotein ultrasound for early detection of the HCC. And larger scale validation study is planned now, and we'll see the result hopefully in the upcoming years. So conclusions. So, and the ultrasound and alpha-fetoproteins are recommended as standard surveillance tests for the HCC early detection. However, their performance is not good. So MRI could potentially be an option for HCC surveillance, especially in high-risk cirrhosis patient, or the quality of the ultrasound is expected to be poor, especially for those with abdominal obesity or underlying NASH as an underlying etiology of the cirrhosis. GALAD score has the outstanding performance for early stage of HCC detection, and more data are going to be available sometime very soon. In our phase 3 study, and the liquid biopsy, particularly cell-free DNA methylations and extracellular vesicle, might be an effective surveillance tool for early detection of the HCC. Finally, it's crucial and that any of the biomarkers that is out there that they need to have a larger scale validation, especially phase 3, because of the phase 2 always overestimate the performance of the novel biomarker for the detection of the cancer. So there are a lot of the promising markers, and hopefully sometime soon, and many of these markers will be confirmed in a larger scale phase 3 study. And these are my collaborators and our research team. Thank you.